I'd like to welcome everybody to today's webinar where we will be discussing strategies for MIPS and CPC Plus. My name is Scott Mash and I'm joined by Ms. Kathy Costello. And we would also like to thank Dr. Kataka and Bambi Huffman for the opportunity to present. And with that, I'm going to turn it over to Ms. Kathy Costello.
Thanks so much, Scott. Good morning, everyone, or good lunchtime anyway. I just want to give you a kind of high-level view of where we're going to go over the next 45 minutes. The thrust of this presentation is to show the relationship of CPC Plus to all of Adena's other payment programs, explain the particulars about CPC Plus, financial, clinical, reporting, quality, and look at the quality reporting in light of all the other quality reporting that you need to do for other programs, and then talk about how your work with CPC Plus feeds into the MIPS scoring that you all will be doing as part of the larger Adena group this year. Let's start with a financial overview so that you have a good sense of where CPC Plus fits in everything else that Adena is doing. The difference over the past few years, and certainly in 2017 on, there's a difference between what used to be what I call a linear approach to care, and that is a patient was seen in the office or is admitted into the hospital, and then you bill for that service and you get paid for it. You still have a fee-for-service model, and Adena has many parts of what they do are fee-for-service, but it is now affected by other aspects of what you do. In the hospital area, it includes bonuses and penalties related to hospital readmissions, quality reporting of different types, and the cost of care to the Medicare patients. There are also bundled payments that affect some of your specialty areas, especially your surgeons and your oncologists, and this is a shared approach to cost and payment for the specialist and for the hospital. The third area that affects the hospital and certainly all of you providers is the Shared Savings Program, better known as Medicare Shared Savings Program, or MSSP. And that is something that Adena is in its second year, and this is something where you share with Medicare any savings that you produce on the Medicare patients that are fee-for-service that you see in a given year's time. On the ambulatory side, there are other types of payments that you receive and incentives that you are party to. The first one, and one that you're familiar with, you've been doing it for now 6 or 7 years, is meaningful use. Even though in the Medicare side that program has officially ended at the end of 2016, the Medicaid payments for use of your technology will continue to 2021. There are numerous Adena providers who will still be doing meaningful use, and your staff will continue to report that for you and receive incentives for the organization. The next box down is the new MIPS reporting, and that is a combination of meaningful use, quality, practice improvement, and cost. We'll talk some more about that later. I know that you all have received a lot of education in this area, but let's just say that you are being set up as providers this year to hopefully receive fairly good bonuses on top of your fee-for-service work with your Medicare patients. The next 3 boxes down are really where we're spending a lot of our time today, and that are these new areas that you will be involved in at the beginning, actually right now in January. CPC Plus, which is the Medicare program. You are what is known as Track 1. The second one is Ohio CPC, which is the Medicaid equivalent of that. And the third area is CPC Plus Ohio Medicaid CPC commercial payers. So these are commercial payers who have linked on to either the CPC Plus or Medicaid CPC to provide additional dollars to primary care practices for their care management of their patients. In Ohio, there are 12 different commercial payers involved in this program. The financial payments, so you understand the flow of dollars to your practice this year. For primary care practices that are engaged in CPC Plus, because you are Track 1, which is basically a fee-for-service model, you will continue to submit claims the way that you normally do on your fee-for-service patients and be paid the same way that you have been in past years for the work on those patients. In addition to that, you will receive a per member per month care management fee for your patients for providing more of a hands-on experience and especially working with your chronic care patients. The thing to keep in mind, and we'll talk again about this a little bit more, but your specific situation at Adena as a CPC Plus site, you will receive your claims, you will receive your per member per month. You will not be eligible for an additional bonus payment as part of CPC Plus because you are part of a larger shared savings. And what CMS has set up with shared savings is to say if you're part of an MSSP structure, you share the benefits of that and we are not going to pay you an additional bonus for being part of CPC Plus. The CPC Plus payment per member per month is actually due out. The first one is due out by the end of January. Normally, it would come out at the beginning of each quarter, but because this program is just ramping up, they're a little bit late on getting those initial payments done. Those initial payments are based, and we'll look at the risk stratification that CMS uses in 1 second, but the initial payments are based upon the risk stratification as it is done by CMS. You do not provide CMS your idea of how to classify the patients. They take the claims that have been submitted to them historically and they risk adjust it in a program called the HCC, which we'll look at in just a second. But I have to emphasize very strongly to you all that you make sure that your coding is correct, because the way that you code your patients, especially for those with chronic conditions, will affect the HCC score of these patients. The HCC score is recalculated at the beginning of every calendar year for groups participating with Medicare in various programs. And this HCC score as part of the CPC Plus is going to be regionally adjusted so that it reflects more closely what is going on in this area. As far as additional financial reporting for the CPC Plus sites, this will be handled by the Adena Finance Office, and it includes individual budgets that must be submitted by each site. So all the information for CPC Plus is site-specific. And the thing to keep in mind here is that there are no CPC Plus funds. They will be awarded by site, but no funds can be used for technology costs. They are to be used for care management. The risk stratification that CMS uses is called the Hierarchical Condition Category, or HCC. Because you are Track 1, there are 4 tiers. If you were in the more advanced track, which includes a lot of behavioral health issues, there are 5 tracks, just so you're aware of the difference of the two, but all the Adena sites are Track 1. The way that CMS sets up the HCC scoring for Track 1 is they divide the 4 tiers into just 25th, 50th, 75th, and 100 as far as the points scored. So the lower your score, the healthier the patient is assumed to be. The higher the score, the closer to 100, these are your sickest patients. You will find, just so you understand how this works, you may have two patients who have identical conditions. Let's say they have 2 or 3 chronic conditions. They're diabetic, they have COPD, they have heart failure, and yet they're scored totally differently, and they may have as much as a 20 or 30 points difference in their score. This can happen for one of 2 reasons. The HCC scoring is designed to take into account age and sex factors and to a certain degree socioeconomic. And so you will see a great variation. But the second reason you see it is, as we just mentioned, it is absolutely critical that your coding be correct in this area, because we have seen cases where people have 3 and 4 chronic conditions and are coded with somewhere, or end up with an HCC score of 0 to 20. So you definitely don't want that. You want your scoring to reflect how sick your patients are and the type of care that you're taking of them. The average amount of your per member per month cost will be $15, but as you can see from this slide, the actual amount will depend where the patients fall within this risk stratification. Here are the private payers, the commercial payers, who are participating in CPC Plus. There are 12 of them in Ohio. The whole process of working with the private payers as part of CPC Plus is a direct relationship between you as practice site and Adena as an organization and the private payer. This Medicare does nothing to intercede or to intervene with your relationship with the private payer. Each payer is free to set up their own per member per month fee that they pay you for managing their patients, and that can vary from each payer to each payer how much they pay. But each payer will set up their own procedure for sign up on this and to work with you on the contracting end. We will talk separately about the Medicaid program in just a minute. So let's talk about CPC Plus and the specifics to it, or about it. The first area is the clinical area, and I am sure, since all of you are primary care sites, that you really do have a good grasp of this area, because the Track 1 model is very, very close and mimics the PCMH model. So patient-centered medical home and your work in this area will set you up well for CPC Plus. The first area in the clinical is that you must have increased availability for the patient. Some people get confused as to what CMS means by 24/7 access. This does not mean that you have to have someone 24 hours a day responding to patients' questions, complaints, queries. But you do have to have your system set up to allow access to your EHR system. So for providers that do need to correspond with patients and reach out to them, they have access to that medical record. And you should have a procedure to allow, whether it's a call center or something else, to take information and to route patient after hours calls. This frequently also represents an extended care day within the office, but that's something that is not specifically defined by CMS. The next 2 areas for increased availability have to do with what you do when you receive your list of assigned patients from CMS. You need to assign 95% of those patients to a practitioner or team, because this is the team approach. And then you need to organize your workflow so that the patients have access to that same team whenever they call or come in for a visit. Make sure that you have your high-risk patients assigned as quickly as you can when you are part of this program. The second area is care management, and this really requires you to take the list that is provided to you, look at the risk stratification, look at your own records to determine what are the chronic conditions, and then to set up basically a chronic condition monitoring program. part of this that is specifically required is to set up a transitional care management so that as patients are released from the hospital, that you pick up immediately on their care and follow up with them. CMS specifically requires that 75% of your patients who are discharged from the ED or inpatient as part of a chronic care management program are contacted within 2 days. They seem to give a little bit longer for the ED visit, up to 1 week. But if you are going to do transitional care management, traditionally it would be you should contact them within 2 days and then see them within 1 to 2 weeks. The next area is care coordination. This, fortunately for you, you are part of a very strong and focused group in organization within Adena, and so there are a lot of this that you don't need to worry about point by point, and care coordination is one of those. The ACO and the IT department are working to help coordinate the care to make sure that you get information on when patients are hospitalized outside of the Adena system, how you receive notices to this, and how you respond to it. So there will be more information internally for you on that. The next area, patient and family engagement, is one that is brand new for everyone. I am going to assume Adena does not have a similar structure, but you are required to set up a patient and family advisory council. And this council consists of patients within your practice, and you are required to have them meet at least once a year. You should take the information or the recommendations that they make about your practice and incorporate those that seem appropriate, and have this group help you plan how to do patient self-management.
Yeah, and it's also important that you take minutes, you record the attendees, so that way you have a nice document should CMS request additional information as part of the CPC Plus program. And really, this family and patient family engagement council is your chance to find out how you can really get those patients engaged more, get them engaged in their own care. Find out what services they think would help in their care as well, like maybe some nutrition counseling for diabetes, or just some other small programs. Some good feedback will come from this group.
Right. Then the very last thing that you need to do with your patients, you don't run it yourself, but CAHPS surveys will be done to show patient satisfaction with the practice. The last area for the clinical side is the planned care and population health, and this requires the payers are supposed to give you feedback every quarter on their particular beneficiaries to show what the claims data shows about the care that you're providing. You're supposed to review that on a quarterly basis for 2 of the measures. I'm going to guess it has to do with inpatient and readmissions, but we'll see exactly what's provided. And the second thing that you are supposed to be reviewing on at least a quarterly basis are 3 of the clinical quality measures that you will be tracking. So you're supposed to be reviewing this as a group. You should know that webinars and calls will be established once a month for people within the practice who have key roles, whether it's the leadership, practice manager, care managers, IT, or support. And on a quarterly basis, the physicians or practice champions will also have their own call. The meetings, there are 2 face-to-face meetings scheduled at the statewide level, and then I know they're going to do a national meeting once a year. Usually they do that towards the end of the year or in January. And the meetings are designed not only to give you the opportunity to talk amongst yourselves, but also to have dialogue with payers. The reporting done, you are required to report once a year on 9 clinical quality measures as part of the CPC program. We're going to look at those in just a minute. You officially report that once a year. I don't know if there's going to be like an informal report quarterly just to see how you're doing. You're supposed to pull that yourself and review it too. As I said, the payers will all give you feedback on a quarterly basis, and then the CMS updates annually your HCC, and that in turn will update all your lists. The last thing to keep in mind is you will be required to meet all the technical upgrades that are part of Meaningful Use Stage 3. Do not worry about this. Your technical team has this well under control. It is something that will just be a given and will be documented to CMS. So very quickly, we're going to look at the payment models and how that fits in with the MIPS structure, what you're doing. There are 5 different areas. CMS has set up a ton, actually over 20 now, different pilots for alternative payment models that they are trying to see, does this improve care, does it lower costs? And of those, 5 of those models have been designated as MIPS APMs, so MIPS alternative payment models. You are in actually 2 of these because they are not mutually exclusive. You're in CPC Plus, you're also in shared savings. There's a different track of shared savings is another form of APM. End-stage renal disease model and an oncology care model round out the 5 that are considered MIPS APMs. Your engagement in CPC Plus becomes part of the bigger picture when you also consider Medicare shared savings. So what Adena is doing and what you are participating in as a group for MSSP, CPC Plus, MSSP is the umbrella, CPC Plus is just an offshoot of that and should represent more intensive work in the primary care practices, but it is all considered part of the shared savings program. So you will not be excluded from shared savings. You will participate the same way that all your other practitioners that are at Adena that participate in shared savings do. That does not change your status for shared savings. The only thing that changes is your reporting. Your reporting for shared savings is part of the larger group. You do not do anything differently for that. But site-specific, you will be required to report CPC Plus information. You were considered a dual participant under shared savings and CPC Plus. Just the term that's being used, you are seeing exactly how that works, but it's just referred to as a dual participant. There are it's almost exactly half of the CPC Plus participants are also in MSSP. So just to give you a sense, you're not in there by yourself. There are a lot of dual participants. How does this work with MIPS? As you know, MIPS is just rolling out this year. I know you've received a lot of education on this area, so we're not going to go into a great deal of detail, but I just want you to understand how CPC Plus fits in with MIPS. So because you're an alternative payment model, the significance of being part of that as part of MSSP is that it changes the way that CMS scores you in these various categories, because MIPS takes the 4 areas: technology use, quality reporting, cost of care for the patient, and clinical practice improvement, and rolls it into one overall score. Because you were an alternative payment model, they change how much they value each one of these in a given year. So if you were an individual provider reporting, your percentages would look different, but because you're part of a shared savings, half of your score, 50% of your score in 2017 comes from quality, 30% comes from your technology use score, and 20% comes from clinical practice improvement. The significance of this is that you want, as a group, to achieve hopefully 70 or better in your scoring, because 70 or better puts you in the highest category for MIPS bonuses. Here's the breakdown of the payment for MIPS. So if you don't score at all, you receive a 4% penalty in 2019 based on 2017. But you are not there. You are at the other end of this chart where you're at least expecting a 4% bonus because you'll meet all the reporting requirements as an organization. Adena will do this. And we're going to try to maximize that as much as possible. So not only will you be eligible for the 4%, I'm sure you've seen this chart before, but you will move over 2 more columns to the 4th column and hopefully be eligible for any exceptional practice bonus that comes along with it. I think CMS is a little disingenuous when they say practices could earn 14%. The reality is you will earn a bonus, but because CMS operates as all federal agencies do under a requirement of budget neutrality, just how much of a bonus you will be eligible for depends on how everyone else in the country does.
Yes, and that's why these programs are difficult, because for there to be winners, there must be losers.
Right. So our goal is obviously to get you at least a 4%, but I think realistically, we may be able to see at the federal level that maybe 5-6% or possibly even a little bit higher may be what's given to the exceptionally performing groups. The last column on the right, the advanced APM, is when you don't have to report, but because of the APM you're in, automatically receives bonus payments of 5%. This is designed by what type of APM you're in. Right now, Adena is not in an APM that gives you that automatic 5% bonus. You're going to have to report to get it. But in 2018, just so you're aware, there are new regs coming out that Adena is starting to look at that has a new track called ACO Track 1 Plus that may or may not be something that Adena is interested in, but should you decide to go with that, you would then fall into this advanced APM and receive an automatic 5% bonus. Okay, so I'm going to turn it over to Scott to talk a little bit about your reporting for this year.
We're not going to go into great detail about reporting because Adena's support team is going to handle the reporting for you, but we think it's important that you at least have an understanding of how the reporting works and what's being reported. So for the 2017 calendar year, things are going to be a bit complex. In the leftmost column in green, this will be the Medicare, really the MIPs reporting. Now, a lot of your reporting is going to be done through the ACO, through your shared savings ACO. There's some additional reporting that's going to be done under CPC Plus. It is important to see that there's a slight change in terminology with it being eligible clinicians or ECs. Now, that definition is more broad than what we've seen in the past with meaningful use and what we refer to as eligible providers. In the middle column, there is still some meaningful use reporting that's going to be done. There are some of your Adena providers are eligible for the Medicaid incentive program, and there's still funds available. So those providers will still be reporting under traditional meaningful use under Medicaid, where we still have thresholds. And again, your Adena support team takes care of that. The hospital, in the rightmost column, the hospital still has meaningful use. Now, those measures have changed a little bit, but meaningful use is going to continue for the hospitals. Now, since the macro final rule came out so late in 2016, CMS kind of had to back off a little bit about with regards to what had to be reported, and there were some providers that were going to struggle just to report anything, so they provided several different options. You guys are not in this boat. You guys are going to be reporting for a 90-day to a full year, depending on if it's ACO reporting or if it's the ACI or what used to be meaningful use. So you guys will be eligible for all incentives under the program. So let's talk a little bit more about reporting. The ACI pillar, or what used to be referred to as meaningful use, under the MIPS program is going to be reported at the group level. Now, there may be several groups if you have multiple TINs, but the thing to remember is it's going to be done at the group level. Your CPIA reporting, this is your clinical practice improvement activities. We're going to talk a little bit more about this later. This is going to be done at the group level as well, and it's going to apply to everyone within the ACI, or I'm sorry, the ACO. Now, there are some areas where providers will have to report to different programs and to different payment models. Now, this is particularly true for many of you providers at Adena who are participating in the CPC Plus program and the Shared Savings ACO. Reporting will be done under both programs. Failure to report under both programs would result in a penalty for the program in which you did not report. The overall score will come from, for the providers participating in CPC Plus and the ACO, your MIPS score will match what comes from the Shared Savings ACO. Now, if you're participating in different alternative payment models outside of the ACO, you would be assigned the highest score of the two that you received. All right, we're going to skip over that. We're going to talk real quick about the clinical practice improvement activities. Now, these are new for reporting, but these are probably activities that your quality and process improvement team, your IT department, or even your care teams were already doing. It just may need to be a little bit formalized or at least documented. Since you guys are participating in the Shared Savings ACO, it would require activities equaling at least 40 points, and that becomes 20% of your score. So it's kind of either you get all 20% or you don't get any of it. You guys are going to be covered. You're going to get your full 40 points just by participating in the ACO. I'm going to turn it back over to Kathy real quick for quality reporting.
Okay, we are going to look at the quality, to look at the crosswalk between your CPC Plus, your ACO reporting, and your MIPS reporting, so you understand how you get scored this year. CPC Plus, you have a requirement to report on 9 quality metrics. We will look at those in just a second. Shared Savings, you report on 34 metrics, but only 11 of those are used to score you for MIPS. So you report all are used in your shared savings to determine how your shared savings gets calculated, but only 11 of those go then to calculate your MIPS bonus. I know you've seen these graphs any number of times. This is the breakdown of the shared savings quality metrics. First area is patient caregiver. None of that is used in your MIPS scoring. That's your CAP survey. The second area is your hospital costs area, and of this, there's only one of the ACO metrics that goes into MIPS, and that is the screening for future fall risk. Gets weighted into the MIPS score. The third area is where most of your MIPS scoring comes, and it's your preventive care, it's your flu, pneumococcal, weight screening, tobacco use, depression, colorectal mammography. These all are taken into account when determining what your MIPS bonus should be. In your last area, your at-risk population, your diabetes composite, your blood pressure control, and your IVD with aspirin control are the 3 areas that are calculated. Just so you're aware, you do not do any separate reporting other than the shared savings reporting of quality metrics to have the MIPS score calculated. CMS will automatically draw your results out of your shared savings report. When you then overlay it with your CPC Plus, you're looking at many, many, many of the same measures. So these areas that are highlighted in green are also measures that you are tracking as part of shared savings. Depression remission, controlling high blood pressure, diabetes A1C. Of this group, you have to report on at least 2 of these measures for CPC Plus. And as I said, the CPC Plus quality reporting is separate from your MIPS Medicare Shared Savings reporting. It is done through the CPC Plus portal, and your quality metrics is reported at the group practice level, so practice site level, as opposed to either the Adena level or the individual level. The second part, you have 3 parts to your quality reporting for CPC Plus. The second one also you are required to do 2 quality metrics and report on it. One of those, screening for future fall risk, is also part of your ACO reporting. Of the remaining 3 areas, these are new areas that you have not been tracking yet, and this high-risk meds in the elderly, dementia assessment, and initiation of drug and alcohol treatment. So you will have to make that decision what the other metric is that you are going to track. The third group, so you report on a total of 9, 2 from the first, 2 from the second, 5 from the remaining, the third group or any of the remaining measures. And of these, again, you are already tracking 5, colorectal cancer, diabetes eye exam, tobacco use, low back pain imaging, and breast cancer screening. So it should be relatively easy for you to standardize your workflow based upon all these quality metrics. Keep in mind, in case you had missed that notice, you are supposed to report to CMS sometime in the next week through the CPC Plus portal which of the quality metrics you are planning to track. We suggest, and I think CMS suggests also, to try to track as many as possible above and beyond the 9, because it'll give you a better sense of how you're doing, and should you need to capture more measures next year, it gives you a head start on what you're doing. Let me make just one comment on the Medicaid CPC program. We haven't talked too much about it because you automatically come into that program as a result of your Medicare CPC Plus. So you did not apply separately or anything else. And this year we do not know if Medicare is going to link to the work done with CPC Plus on the practice management side and just accept CPC Plus. We will have to see. But as far as the quality metrics, you do not have to report to Medicaid on your quality metrics. These are strictly drawn by claim information through the Medicaid managed care programs. So all the Medicaid managed care payers are part of this, and they will consolidate that information with Medicaid and track that. If Adena does very well as TIN, because the way that Medicaid tracks it is at the organization level as well as the group level, you may actually be receiving some shared savings from Medicaid, separate from what you receive from Medicare. So let me turn it over to Scott for our last piece about the technology, and then we'll let you get back to your day.
Yeah, that's what I shared earlier. Meaningful use really doesn't go away. They changed the terminology really to ACI, but you know, the technology, the ability to capture and report data through your EHR remains the foundation for all the payment reform programs going forward. Now, on this slide, we're showing what are the ACI or meaningful use measures for Adena in 2017. Numbers 1 and 8 are really kind of behind the scenes things that your IT department and others are already going to handle for you. So physicians and their care teams will be responsible for 2 through 7. Those where it says in red, required for base score, those are measures in which you have to either say yes or have at least one patient. If not, then you're not going to be able to get any scoring in the ACI category. Now, keep in mind, couple little changes with respect to what we saw under meaningful use. There are no thresholds. Those go away, so there's not that 10% or 50% threshold. But also your exclusions go away. Also, you can see in the scoring column that the provide patient access, which is your portal measure, pushing data to the portal, is weighted at 20%. Also, your electronic summary of care or the electronic referral measure is also weighted 20%. So those two, you are going to get double credit. The goal is to get up to 100 points and capture, get maximum credit for your ACI measure. So again, you don't want to get a 0 in any measure. You want to get as high as possible, but there are no pre-assigned thresholds here. And you can see that these measures really coincide with what you saw under traditional meaningful use except you don't say CPOE. You're not going to be scored on CPOE. CMS is focusing on the interoperability measures, the sharing of patient information across the continuum of care. Now, there are some clinical practice improvement activities that give you a bonus under the Meaningful Use or ACI. We're going to work with your IT department and with your quality department to ensure that you guys get the maximum credit for those activities. For example, one of those is the use of clinical decision support within your EHR. We're going to make sure that your CDSs that are enabled within the ECW and Meditech EHRs meet the requirements so you get that 10% bonus.
And reflect your work with the CPC class.
Absolutely.
Which I think that way it'll act as a trigger and a reminder for CPC class.
Now, the good news is under this ACI category or pillar, there are 140 points available, so there's no reason not to get 100%.
Okay, last slide, and we'll let you get going. Technology, things that you need to do. Your technology group is way far ahead of this, so do not worry about that. They are getting you aligned for anything that you need to do for stage 3 when you're required to do it. On the clinical area, as I mentioned, you have to submit your quality information that you want to track this year to CMS, and you will develop your workflow based upon guidance from the Adena technical team as far as any of the meaningful use criteria. On the financial side, the Adena finance group is going to be working with you to make sure that the budget is correct at the site-specific level, and this will be monitored at the beginning and end of each year. So that will be something that you'll have an ongoing look-see as to what's going on. So with that, we are done talking about what's going on.
Let's see if we had no questions submitted. If you guys have any questions, you got a follow-up question or something comes to you tonight, feel free to email Kathy and me. We are on site at Adena usually once every.
Thank you so much, and you all have a great day.